though from the medial epicondyle, you have got the common flexor adhesion. They have got more pull than the common extensors. Babu, అది కూడా తలుపు తీరా నాకు గాలి వస్తుంది, అది ఎలుగు సావచ్చుని వస్తుంది. Yes sir, please go ahead sir.
56 years female with closed segmental fracture of left tibia and fibula, sir.
So what type of fracture is a stress fracture or
stress fracture, sir?
So she is osteoporotic. What
Yes,
is the
sir.
BMD score?
Yes,
What
sir.
is the BMD score? Minus 2.5, minus 3.5, minus 4.
-4, sir.
అది చూసుకోవాలి. Yeah. Yes sir, go ahead.
We have done close reduction internal fixation with.
What is the indication for nail in these stress fractures?
Sir, what is?
What is the, you have done there are stress fracture,
Yes, sir.
proximal and distal stress fracture. They are incomplete fracture because of repetitive stress, or there may be fragility fractures. What is a fragility? Weak bones. So fragility fractures more common after 70s, but she is 56.
56.
అంతే కదా?
Yes, sir.
So there is gross up. So you have to look for the normal, అంటే ఆపోజిట్ లింబ్ కూడా చూడాలి దీస్ కేసెస్లో. అండ్ యూ హ్యావ్ టు గాట్ ఏ బిఎండి డెఫినెట్గా చేయాలి, ఆర్ డెక్స్ట్రా స్కాన్ ఖచ్చితంగా చేయాలి ఇటువంటి కేసులు. అదర్వైజ్ దే విల్ గో టు ద హిప్, దే గో టు ద అదర్ లెగ్, సో ఆన్ సో ఫోర్త్, అట్లా జరుగుతూ ఉంటాయి. సో దట్ షుడ్ బి ఎవాల్యుయేటెడ్ బిఫోర్ ప్లానింగ్ ఫర్ ది మేనేజ్మెంట్. సార్ చేయమన్నారా? సరే, ఓకే, రైట్, నో ప్రాబ్లం. సో దట్ ఈస్ అ ప్రాబ్లం. అర్థమైంది కదా? So in the fragility fracture, you have to look for the everything. You have to look for the hip, you have to look for the femur, you have to look for the other opposite leg కూడా చూడాలి. ఎందుకు చూడాలంటే ఇప్పుడు దీన్ని వదిలేస్తాం అనుకో, నెక్స్ట్ అట్లా దే ఆర్ కీప్ ఆన్ కమింగ్. అర్థమైంది కదా? సో యూ షుడ్ బి కేర్ఫుల్. అర్థమైందా? ఇప్పుడు ఆంజలి సార్ వేస్తున్నారు కదా, స్టార్ట్ చేయమన్నారు కదా. ఆంజలి సార్ అని వేస్తున్నారు, స్టార్ట్. ఆంజలి సార్ వేస్తున్నారు, అందుకే అడిగింది. ఎస్.
36-year-old male with
తలుపు తీసి గాలి రావాలి.
acromioclavicular joint
disruption
of right shoulder.
ఒక్క నిమిషం, తలుపు తీసి గాలి రాని. ర్యాట్స్ స్మెల్ వస్తూ ఉంది. ఓపెన్ చేయి, 2 తలుపు ఓపెన్ చేయి. ఒకటి పట్టుకుని ఒకటి తీ, అది కూడా తీ. ర్యాట్ స్మెల్ వస్తూ ఉంది. ఎస్ సార్, గో హెడ్.
36-year-old male with AC joint disruption of right shoulder.
Yes.
It is Rockwood type 2, sir. We have done ORF with endo button, double endo button with K-wire fixation for AC joint for additional stability.
Show me the endo button.
Sir.
Zoom the image, endo button image. దీంట్లో చూపించాలి. దీంట్లో ఎండో బటన్ జూమ్ చేయాలి. పిక్చర్ ఏం లైటింగ్ వస్తుంది, ఏం కనపడం లేదు. ఎండో బటన్ ఏం కనపడలేదుగా, ఏం ఎక్కడో చూపిస్తుంది, ఇమేజ్ ఎక్కడో ఉంది.
Sir.
So the endo buttons are titanium endo buttons.
Yes, sir.
So what is the thread? What type of thread? Non-absorbable. Is it bond or Arthrex?
Arthrex, sir.
Arthrex. What is the diameter? 2 mm, 3
2
mm?
mm, sir.
2 mm. All is well. So there is perfect anatomical reduction. So when do you want to remove the K-wire?
K-wire after 3 weeks.
3 weeks. Okay, right. Go ahead, sir. Next.
Okay, sir.
Yes. వద్దు, మీరు వదిలేసండి, యూ కమ్ అవుట్. స్టాప్ చేసి వచ్చండి. సాయి చరణ్ రా, పైకి రా, స్టేజ్ మీద రా. అవును, జర చూపి, స్క్రోల్ ద స్లైడ్స్. యూ జస్ట్ స్క్రోల్ ద స్లైడ్స్. ఉండు ఒక్క నిమిషం ఉండు. స్క్రోల్ ద స్లైడ్స్ స్క్రోల్ ద స్లైడ్స్. Beautiful. How many? 10 or 12? Sorry, okay, right. వచ్చేసాను సార్, వదిలే. ఓకే, రైట్, వచ్చేసాను సార్.
దీనిలో ప్లే అవుతుంది.
ఉండు, సార్ వస్తారండి. నేను ఆన్ చేశారు అడిగితే స్టార్ట్ చేయమన్నట్టు, మాకు లేట్ అవుతుంది, స్టార్ట్ చేయమన్నట్టు. నేను అడిగింది ఇప్పుడు ఎక్సెల్ దగ్గర ఉన్నప్పుడు స్టార్ట్ చేయమన్నాను. స్టార్ట్ చేయమంటే సార్
సెకండ్ యూనిట్. వడ్డీలు
ఓకే బాబు స్మెల్ వస్తుంది పోనీ స్మెల్ వస్తుంది భయంకరమైన స్మెల్ వస్తుంది. ఇది షో మీరు కేసెస్ స్క్రోల్ చేయండి. ఓకే నెక్స్ట్ 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 ఓకే యూనిట్ 1 అది. ఎస్ యూనిట్ 2 ఉండే దాంట్లో ఉన్నాయా? స్క్రోల్ చేయి, స్క్రోల్ ద స్లైడ్స్. స్క్రోల్ ద స్లైడ్స్. యూనిట్ 3. Scroll the slides. Yes. 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 ఎస్ అయిపోయినాయా? ఓకే రైట్, థ్యాంక్ యూ. మీరు ఇక్కడ టైమర్ పెట్టాలి సార్. ఎవరైనా ముందే చెప్తున్నా, ఒక టైమర్ పెడితే ఎక్కడైనా సరే టైమర్ ఉండాలి. దట్ ఇస్ వెరీ వెరీ ఇంపార్టెంట్ ఆఫ్ ఏ ఎడ్యుకేషన్ ప్రోగ్రామ్. ఒక టైమర్ పెట్టాలి. చెప్పాను మీకు, సంబడీ షుడ్ హ్యావ్ టు డొనేట్ ద టైమర్, డిజిటల్ టైమర్. ఒక టైమర్ ఉండాలి, ఎందుకంటే ఇది మార్నింగ్ టైం కదా, అందరూ టక్ తీసుకుని వెళ్ళిపోతుంటారు.
87 years female.
వద్దన్నారు కదా. నాకు తెలిసి నాంజలి సార్ ఏమో స్టార్ట్ చేయమన్నారు.
ఓకే సార్.
మీరేమో ఇట్లా అన్నారు. సార్ కేజీ రెడ్డి సార్ వస్తున్నారు. కేజీ రెడ్డి సార్ ఇప్పుడు వస్తారా? 5 minutes వస్తారా? ఎన్ని కేసులు ఉన్నాయి ఈరోజు? ఒకటి
8.
ఏది
టీకేఆర్
5-6 మరి సార్ వస్తున్నారంట. 5 minutes ఉన్నారు. వెయిట్ చేస్తాం. లేదు సార్ కాల్ చేయమంటే కాల్ చేస్తాను, నేనే కాల్ చేస్తాను. కేజీ రెడ్డి సార్ కాల్ చేస్తాను నేను.
జగదీష్ సార్ వస్తాను. జగదీష్ సార్ వస్తాను.
నువ్వు కేజీ రెడ్డి సార్ అంటే ఇప్పుడు
సార్
రే బాబు తలపే పక్కన కాల్ రాని గాలి రాని.
లైవ్ స్టార్ట్ అయింది.
లైవ్ ఆల్రెడీ ఉంది.
చెప్పేసి
జగదీష్ సార్ ఒకసారి కాల్
స్టార్ట్ చేస్తా.
మీరు కాల్ చేయండి సార్. నేను సార్ చెప్పాడు, నువ్వు చెప్పు డైరెక్ట్ అయిపో. సార్ ఆంజీ సార్ కాల్ చేశారంటే స్టార్ట్ చేస్తున్నాం సార్. మీరు ఆర్ ద ప్రెసెంటర్, ఇట్ ఈస్ యువర్ టైమ్. యు ఆర్ ఎగ్జామ్ గోయింగ్ బ్యాచ్. మా ఎగ్జామ్స్ అయిపోయినాయి. అవును గట్టే ఓకే. ఒక్క పేపర్లో 3 questions వచ్చినాయి. అది నేను ముందే చెప్పిన వాళ్ళు. ఐ టోల్డ్ లాంగ్ బ్యాక్. ఇప్పుడు మొన్న విషయాలు కూడా వేసాను. ఐ సెడ్ ఏసీటీ, ఆటోలాగస్ కాండ్రోసైట్ ట్రాన్స్ప్లాంటేషన్. ఐ సెడ్ స్టెమ్ సెల్ థెరపీ. ఐ సెడ్ జీన్ థెరపీ. అన్ని పక్కపక్కనే, అన్ని రాముడు భీముడు, కొద్ది మార్పులు. ఒకే పేపర్లో 30 మార్కులు. ఏమన్నా అదే డిఫికల్ట్గా అదే చదవాలి. దెర్ ఇస్ ఎ చాప్టర్ ఆన్ దట్. వీ హావ్ గాట్ ఎ సెమినార్స్. ఇప్పుడు మొన్న కూడా వేసాను లాస్ట్ దిస్ అక్టోబర్. ఏసీటీ ఈజ్ ఎ సెమినార్ ఫర్ విశాల్. ఇది సాల్ ఓపెన్ ఎంఆర్ఐ అంటే ఇస్ నాట్ క్లాస్ట్రోఫోబియా. క్లాస్ట్రోఫోబియా అంటే క్లోజ్డ్ చేంబర్, చిన్న ఇప్పుడు అర్థం కాదు, వైడ్గా ఉంటాయి. ఓపెన్ ఎంఆర్ఐస్ అంటే అట్లా క్లోజ్డ్ చేంబర్ ఉంటుంది, ఓపెన్ చేంబర్ ఉంటుంది. సో దే విల్ బి డోంట్ హ్యావ్ ఫియర్ ఎస్పెషలీ. సో ద ఫియర్ ఆఫ్ ఎంఆర్ఐ, టిక్ 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 అంటారు ఉంటుంది ఎంఆర్ఐ. పోయినారు ఎప్పుడైనా లోపలికి? సో క్లాస్ట్రోఫోబియా మీన్స్ క్లోజ్డ్ చేంబర్. ఇన్ క్లోజ్డ్ చేంబర్ యూ గట్ అ ఫియర్ ఆఫ్ క్లోజ్డ్ చేంబర్స్. ఇదే సౌండ్ అనేది సాయంగా. ఏమన్నా కాల్ చేసావా? బాబు ఈ లైట్ వెనక వెళ్ళినా అక్కడ ఉండాలన్నా. ఈ లైట్ ఏమైంది? ఆ లైట్ ఈ లైట్ నీకెందుకు వస్తుంది? కొద్దిగా ఆ లైట్ వేయాలి. ఆ లైట్ వేయవా? లైట్ ఈ లైటింగ్ కనపడదు సార్, వాళ్ళ ఫేసులు కనపడవు, మీ ఫేసులే కనపడ, డార్క్ కనపడతాయి. ఈ లైట్ వేస్తే ఇక్కడ స్క్రీన్ కనపడదు. ఇది ఆఫ్ చేయి, ఇది ఆఫ్ చేయి, ఇది ఆఫ్ చేసి వెనక లైట్ వేయి, కొద్దిగా వెనకైనా. ఈ లైట్ ఇంకో లైట్, ఇంకో లైట్ ఉంది కదా, ఇంకో లైట్. సరే, అది ఇది పెట్టు, ఇది పెట్టు, అది పెట్టు చాలు. ఎట్లయినా సరే మీకు ఆ స్క్రీన్ అనేది డౌన్ అవుతుంది, స్క్రీన్ క్లారిటీ రాదు. ఇది పెడితే వాళ్ళ ఫేస్లు కనపడతాయి, లేకపోతే డార్క్ ఏం కనపడదు, ఏం కనపడదు. అదే చెప్తున్నాను. ఇప్పుడు యాక్చువల్గా డాక్టర్ సాబ్ ఈ పోడియం ఉంటుంది కదా, నేషనల్ కాన్ఫరెన్స్ ఇంటర్నేషనల్, దర్ ఆర్ 2 podiums, రైట్ పోడియం, లెఫ్ట్ పోడియం, రెండు ఉంటాయి. ఈవెన్ ఇన్ ఇంటర్నేషనల్ కాన్ఫరెన్స్, ఇది మీకు కొన్ని జనరల్గా చెప్తాను. సో ఇది కూడా రైట్ పోడియం, లెఫ్ట్ పోడియం రెండు ఉంటాయి. ఎందుకంటే బికాస్ వీ హ్యావ్ గాట్ ఎ పెన్ డ్రైవ్స్ అండ్ ఆల్ దోస్. ఇది లోడ్ అయ్యేటప్పుడు ఆ లోడ్కి వెళ్ళిపోతుంది. అండ్ ద స్టేజ్ ఈజ్ వెరీ బిగ్, ద స్టేజ్ ఈజ్ వెరీ బిగ్. పీపుల్ ఆర్ యూజింగ్ ద టీవీ స్క్రీన్, దాంట్లో చూసి అది ఏం కనపడదు. టీవీ స్క్రీన్ ఈజ్ చుమ్మా, దాంట్లో ఏం కనపడదు, ఏం మాట అనకూడదు. ఒకసారి గొడవ జరిగింది నేషనల్ కాన్ఫరెన్స్. సో యూ హ్యావ్ టు మెయింటైన్ ద బిగ్ స్టేజ్. స్క్రీన్ వెనకాలిపోవాలి, ఇట్లా ఉంటుంది న్యూ షేప్లో, ఇట్లా ఉంటుంది. సో పీపుల్ ఆర్ సిట్టింగ్ హియర్ అండ్ ద స్క్రీన్ ఈజ్ హియర్. సో ఆల్ పీపుల్ లుకింగ్ టు ద స్క్రీన్. సో దట్ మీన్స్ ద స్టేజ్ షుడ్ బి బిగ్. నువ్వు దాన్ని పెట్టామనుకో, అదేంటి, ఇట్ ఈస్ అబ్స్ట్రాక్టింగ్ ద స్క్రీన్. నువ్వు టీవీస్ పెట్టి మనోఫ్యూజ్ పెట్టారు, లేకపోతే ఇది ఒక టీవీ, ఆ టీవీలో ఏం కనపడదు. యూ కెనాట్ అప్రిషియేట్ ద టీవీ, ఏదో నాన్ కావాల్సి పెట్టాము చూసేదాన్ని మీద. సో యూ హ్యావ్ టు మెయింటైన్ ద స్టేజ్, అది ఇంపార్టెంట్. ఆ లైటింగ్ మ్యాన్స్ తర్వాత ఇప్పుడు ఇక్కడ పోడియం లైట్స్ ఉంటాయి. ఇఫ్ యూ గో టు ద స్టేజ్, దగ్గర కదా పోడియం ల్యాంప్ ఉంటుంది, 0 bulbs ఉంటాయి. ఆర్ టేబుల్ సో యూ కెన్ రీడ్ బెటర్ వే. అదర్వైజ్ కెన్ కనపడ దే కెనాట్ ఏబుల్ టు అప్రిషియేట్ బికాస్ ఆఫ్ పూర్ లైట్.
సార్ స్టార్ట్ చేయమన్నారు సార్.
ఎస్ సార్,
కేఎల్ఏ సార్, కేఎల్ఏ సార్, జగదీష్ సార్. అవును సార్,
మరి లేదన్నా
మళ్ళీ సార్.
మీరు ఇచ్చినప్పుడు మీరు చేయాలి, లేకుండా నేను కేజీ ఇవ్వండి, డైరెక్ట్ కేజీతో మాట్లాడతాను.
ఓకే సార్.
మీ ముందే స్పీకర్ ఆన్ చేసి చెప్తాను, సార్ ఇట్లా అంటున్నారు సార్ అని చెప్తాను. విచ్ ఈస్ బెటర్, దిస్ ఈస్ బెటర్, దట్ ఈస్ బెటర్. ఎస్ ప్లీజ్ గో హెడ్.
87 years female with intertrochanter fracture of left femur, sir. Bioid and Griffin type 3, sir.
రివర్స్ ఆబ్లిక్.
Yes, sir. Reverse
చెప్పాలి.
oblique. Yes, sir. We have done open reduction internal fixation with long PFN
2 washers.
with 2 washers, sir.
ఓకే, అది ఫుల్ లెంత్ చూపించు, ఒకటి చూపించే.
TLS, sir.
మరి తీయకపోతే అదే గొళ్ళెము. తీయలేదంటే జాంతనే తీయాలి, చేసే మెడికల్ కాదు. తీయలేదంటే రాముడు అంటే రాముడు, భీముడు అంటే భీముడు. నేను రాముడు చూపిస్తాను సార్, భీముడు తర్వాత చూపిస్తానంటే చల్లదు.
Shivaji in AMC, sir.
సో వై యూ యూజ్ ద వాషర్స్?
Both additional
To
stability.
prevent additional stability, to prevent the proximal migration, and to prevent the Z effect. Z effect కూడా కంట్రోల్ చేస్తుంది. That is the important of washers. You have to have the full length. You go back. Where is the full length? Go to the pre-op. Go to the pre-op. Where is the pre-op? This is the pre-op. Where is the post-op? Post-op.
TLS, sir, X-ray.
అరే ఇదేంది post-op, ఇదేంది సియామ్ పిక్చర్.
Yes, sir.
మరి అంతే. సో ఇట్ ఈస్ నాట్ ఇన్కంప్లీట్, ఇట్ ఈస్ ఇన్కంప్లీట్ ఇమేజ్. సో నో క్లారిటీ కాన్సెప్ట్స్ ఈజ్ నాట్ యాక్సెప్టబుల్. నువ్వు ఎట్లా సీఎం తీసావు కదా, సీఎం తీసి మొత్తం తీయాలి, ఎందుకు తీయలేదు?
Patient AMC-లో ఉంది, sir. TLS.
ఏమ్స్ కదా సార్, నువ్వు సీఎం ఆల్రెడీ చేసి సర్జరీ చేసావు కదా.
Yes, sir.
సర్జరీ చేసినప్పుడు సీఎం ఇది తీసినప్పుడు అది కూడా వస్తుంది కదా. ఎనీ జుజుబీస్ నాట్ యాక్సెప్టబుల్, నాట్ గుడ్, పూర్ ప్రజెంటేషన్. ఎస్, నెక్స్ట్.
8 years old female with 20 days old closed supracondylar fracture of left humerus with no DNVD, Gardlands type 3. First we have tried close reduction. It does not achieve correct reduction, and posterior approach or Campbell's approach, we have opened the fracture site. Because of soft tissue interposition, we removed and wait KVR, sir.
Crisscross KVR.
Crisscross.
Okay. So no peroperative problems, no peroperative problem. Reduction is good, fixation is good. Okay, right.
41 years old male. 4 years. Sir, I think 4 years. 41, sir. 41. 41 years old male with 2 months old closed middle third shaft fracture of left radius with segmental fracture of left ulna. We have done open reduction, internal fixation with plating for left radius and square nail for left ulna with bone grafting.
Which is
And sir, Henry's for radius, Henry's for radius, and won't pick these colors. Middle third. Modified in this one. Middle third. We have freshened the fracture side, sir. Is no, not total, sir. Only at the fracture side we freshen the edges because of sclerotic. That's why. After that we, yes, sir. Yes, sir.
which one is fixed first, radius or ulna?
Radius.
Radius. Radius fixed first. Okay. You said segmental fracture of the ulna.
Yes, sir.
When there is segmental fracture, which one to be fixed first?
Actual ulna, sir, but
Amari?
we fixed radius and we freshen the edges, sir.
So
We
is
did
it
not
good or
open
is it good or bad?
Say,
So what is the disadvantage? Once you fix the radius, you cannot achieve the complete reduction, anatomical reduction of the ulna. See, there is some space will be opened out. And it is a retrograde nail. What type of nail? Talwarkar or square nail?
Square nails. Square nails.
Square nail, Talwarkar square nail. Is it Talwarkar or only square nail?
Talwakar nail.
Talwarkar
Here,
square nail. What is the difference? What is the difference between square nail versus Talwarkar nail?
Blunt tip at Talwakar nail.
Beveled. It has a beveled end. Beveled tip untu daniki. So for negotiation to the curved bone. Deeniki undadu, straight untundi. Yes. So what is the other advantage of square nail? What is the other advantage of square nail? Rush nail also there. Titanium nail also is there. Square nail is there. What is the difference? Rush nail, titanium nail, square nail. What is the difference?
Snail can pierce the other cortex and damage.
Ulnar cortex, huh?
Cortex damage.
Oh.
Sharp ఉంటుంది కదా, sir.
Aha. Mari elastic nail? Titanium elastic, tens. It has got more modulus of elasticity compared to other nails. 316L. Yesterday, Jawahar Jatwan is telling about I am using both, I am using his good retrograde. It is not only retrograde procedure. If you want to do, you can do antigrade also. What is the difference? You can use a titanium nail also. This is all the discussion. These are the PGs. You have to discuss like this. Then only you get a good subject clarity. Just go back. Go back. See? So what is the problem? So some fragment, something maybe, it will give the trouble because it cannot give you the good of rotational stability if you are not good fixation. Ante kada? Yes, go ahead. Go back. Of course, ulna is a upper limb non-weight bearing, but you should be careful. Yes, sir, go ahead.
61 years male with 2 months old intertrochanter fracture of right
You are
femur. Sir.
stabilized with the plaster, no plaster.
Yes.
Huh?
No, sir.
No slab, no posterior, above elbow POP slab, not given. Only arm sling. Arm sling given, not given. Slab.
We need to apply
Good one. Sir, smell వస్తుంది సార్.
slab, sir, but
ఈగ ఇది rat killed in the పైన దాని స్మెల్ వస్తుంది, డోర్ ఓపెన్ చేసి వన్స్ మరి ఇంకా ఉంది సార్.
no, sir, we supposed to apply slab.
స్మెల్ వస్తుంది సార్.
We are supposed to apply slab. No, sir. Swelling is there, sir. Compartment. Yes, sir. Swelling is there and chance to get off compartment also more. Yes, sir. We had seen. Yes, sir. Yes, sir. No, sir. No. Swelling is reduced compared to first day, sir.
61 years male with 2 months old intertrochanter fracture of right femur, sir. We have done close reduction with internal fixation with PFN, sir. 65 years male with intertrochanter fracture of right femur, sir. Boyd and Griffin type 2, sir. We have done close reduction with internal fixation with PFN, short PFN, sir.
Good
Yes, sir.
morning,
Go ahead, sir. Good morning.
These are the cases done in Unit 3. 55-year-old male, 10-year post-op case of middle third shaft fracture of right femur with ILNC2, union present. He came with complaints of pain, sir, at the proximal side. I have done implant removal. Only in the proximal screw there was some pus present, sir.
First came
Pus,
proximal screw.
proximal screw.
Go back first. So how many screws? 2.
Two, sir.
Distal?
Distal, sir.
1 or 2?
2, sir.
Distal also 2. So
60.
do you suspect INF or no INF? Pus is there with INF, no INF. You have to send the pus for culture sensitive.
Sent, sir.
Can pus can be sterile? Huh? Can pus can be sterile pus? Yes, sir.
No.
If the patient is under antibiotic loaded, it can come as sterile pus. This is all important. Yes, sir. Go ahead.
67-year-old male with intracapsular fracture neck of right femur, sir. Garden classification type 2, sir. We have done hemiarthroplasty with cemented bipolar prosthesis for right hips.
What is this red line? What
This
is
is inter teardrop line, sir. This is
inter teardrop
drop
line.
line.
What is this?
there is a lesser trochanter, parallel line to lesser trochanter, to see the alignment.
So there is no pelvic
No.
obliquity,
No,
no limb line discrepancy.
No, sir.
Offset is well maintained.
Yes.
All is well.
Yes.
So what is the age of the patient?
67 years, sir. 67 years.
67.
Lesser trochanter is. Just no pelvic tiltable. Sir? No. No, sir. Yes. Okay. Okay.
So go back. See, there are some 4 lines from tip of the greater trochanter to greater trochanter, from center of the head to the head, from the ischial tuberous space, from the lesser trochanters. All are important. In THR, you should have a 3-point punch. It is from source cell. 1, 2, and 3. Before going for THR, you have to have this measurement.
Yes.
So that is a
Horizontal.
so from. So this is all important for.
Yes. Horizontal.
That is all important. 3 point. So at the level of THR, so you have to go for combined version, not the anti version of femur. That is important. Here you want to have the combined version, no combined version.
No.
That's what Caesar says. Here is not important because you are not looking for combined version here. In THR, we have to have the combined version. That is a very important point. Yes, sir. Go ahead, please.
53-year-old male with a 9-year post-op case of intertrochanteric fracture left side and closed proximal third fracture of right femur with ILNC2, the left side, sir. He came with pain in the right side, sir. This screw was coming out, sir. So we have done implant removal. Bent, sir. Slightly bent. Yes. Yes. Yes, sir. This is left femur, sir. That is right, sir. Both sides he has. Both sides he has. So he was having pain in the right side. Yes. Yes, sir. We have removed and it was very infected, sir. Negotiation. Because it was very loose, sir. Since it was infected, pus was there, sir. So it was easy to remove. Yes. Yes, sir. No, fracture was not infected, sir. Only implant was. With the help of, no, he was walking normally, sir. But after surgery, yes, sir, normal. Sir. Now we have started the toe touch weight bearing with walkers. After walk normally, sir. Yes. No, sir, he didn't have any. And yes. Due to abductor weakness. Uh, disturb the gluteus medius. 75-year-old male with intertrochanteric fracture of left femur, sir.
Screen down.
We have done closed reduction internal fixation with short PFA.
ఫస్ట్ పుల్ చేయాలి తర్వాత డౌన్ చేయాలి.
Thank you, sir.
అది టెక్నిక్ నేర్చుకోవాలమ్మా. నువ్వు లోపలే ఉంటే అట్లా బయట కూడా రావాలి. అయిపోయింది నెక్స్ట్.
No, second unit. No one else.
Case discussion.
Second unit. Actually, second unit is.
Yogit. No. Bharat. Wale ko 2 cases are known.
వెరీ సామీర్
Amer OT.
ఓటీ. కానీ రండి సార్, రండి. మీరు ఉండండి సార్, నువ్వు ఉండండి, దగ్గర ఉండు, హెల్ప్ చేయవాళ్ళకు. ట్రైన్ దేం, నువ్వు రాన్న ముందుకు రా. ఏం పర్వాలేదు.
Good morning, sir. These are the cases done in Unit 2. "40-year-old female with a intertrochanteric fracture of right femur, Borden Griffin type 1. We have done CRF with short PFN for right femur, sir.
ఎస్ నెక్స్ట్ యోగిత్.
Sir? 40, sir. Intertrochanteric.
పాయింటర్ కర్సర్ ఇదో పాయింటర్ తీసుకో. రైట్ కర్సర్. ఓకే.
Sir.
Yes, sir.
Sir?
Principles of management for intertrochanteric fractures. For stable fracture, better with the DHS. For unstable fracture, it is cephalomedullary. Why? Why they are not going for DHS? Yes. Other side also people are going PFN because this is a cephalomedullary. It's more biological. It's more biological, more biomechanical, stable construct. Compared to the DHS, you have to open the muscle, lot of blood loss, time factor, so on and so forth. And there is a end plate resorption also is very high with the DHS. End plate resorption. Yes, sir. Go ahead. Osteopenia and resorption. Cantilever effect. What is cantilever effect? End plate resorption. Suppose you put a plate. Yeah. Suppose you put a plate, DCP. You compress the plate to the bone. Below the plate, because of the stress shielding effect, the bones are become osteopenic. That is called end plate resorption. ఇక్కడ ఇచ్చారు సార్ మన యూనివర్సిటీ ఎగ్జామ్లు ఇచ్చారు కదా సార్. Plate induced osteoporosis. Yeah. Plate.
Compromise
AO classification.
ఏమన్నా సార్
AO.
వర్టిబ్రల్ బాడీస్. యా
24 years female with 2 months old distal third fracture of right humerus, sir. Sir, is
plate induced osteoporosis. Yeah, plate induced osteoporosis or osteopenia. Yeah. Yes sir.
AO classification. Sir. Yes, sir. Sir. Okay, sir. Sir, sir, AO classification, spiral, sir. Spiral. Spiral, sir. Spiral fracture.
Holstein Lewis.
No, sir. Sir.
What is Holstein Lewis syndrome fracture? Where do you get Holstein Lewis syndrome?
Sir, shaft of the humerus.
ఎక్కడ లెవెల్ అప్పర్ థర్డ్ మిడిల్ థర్డ్ లోయర్
Middle.
థర్డ్
Middle third. Sir. No, sir.
Final years. What is Holstein Lewis syndrome? Firdos. What is Holstein Lewis syndrome?
Sir, there is fracture in the middle third and distal third junction fracture, sir, where the radial nerve is crossing. There will be tethering of the radial nerve. Tethering, sir. Tethering of the radial nerve. Due to the fragment, distal. Because from the spiral groove, it is in a close contact with the bone. Close contact.
Any additional factor apart from close contact? Describe the course of radial nerve. How it enters the forearm.
In the forearm, from the lateral septum, it will pierce the lateral septum, intermuscular septum, and it will come in the front and the elbow. From there it crosses.
That is fine. So what does it matter? Let it pierce through the intermuscular system. That's what happens. Why it gets specifically injured, not in the proximal third or the distal third. You said
It
intermuscular septum, lateral penetrates the intermuscular septum and comes into
comes
the
into the anterior aspect.
All fractures will have radial fractures.
Yes.
Some will have, some will not.
Yes.
Why? Because the mobility of the nerve is significantly restricted.
Restricted till the
Because it penetrates the
intermuscular. From there it will be.
caught. It doesn't allow any displacement of the nerve away from the fragments. That is why it is not likely to be injured. The septum is so adherent to the lateral plate. Spike is there. Unless the angulation lateral is not getting that. This will create a problem. So it's called distal end.
Distal end.
Distal end, it's a spiral fracture. There is entrapment.
Entrance.
So it can be pre-op it's good, post-op they will come out with the plaster also because there is improper immobilization. So there is nerve in between the spinal fragments. So
So
usually
here-
transverse fractures, the nerve injury escapes.
Here the X-ray looks fracture is reasonably aligned.
Aligned.
But at the time of the injury, the fragment might have got significantly displaced, angulated. Again, because of the gravity, it has got aligned by itself.
And there is one more point. The lateral intermuscular septum, that is very beautiful point. The lateral intermuscular septum in the distal arm is unyielding, inelastic structure. So there is high chance of compression. That is also important.
Okay.
Yes, sir.
So how do you treat this?
Sir, what if
How do
with
you treat
plating? What if with plating for distal?
Overall for conservation
Mm.
All procedure is only.
Is the role for the
Yes.
treat conservative or not? That can very well.
Good morning.
The first sentence given in Campbell is more than 90% of the fractures of the shaft of the humerus can be treated conservatively with reasonably good functional outcome. That is the first sentence given in chapter. Provided you know how to treat the patient. That is the issue. Okay?
90%.
So many reasons we operate. There is a different issue, but you should know what is what, which to be treated conservatively. There are relative indications, absolute indications, and contra indications.
What are methods to mobilize?
Sir,
Like another one surgery.
slab. Slab.
Above elbow slab, below elbow slab.
Above elbow slab, sir.
You will qualify the slab.
Mm, sir.
Below.
Above elbow, sir.
Above elbow. Any better way of mobilization?
U slab. Huh.
Hanging cast. What is hanging cast? Hanging cast, ideal for this. What of the, you know?
Seen any time hanging cast?
Mm,
Actually, in the first 2 to 3 weeks, till the edema subsides, and in 3 weeks, early callus, soft callus form, will take care of to certain extent immobilization of the fracture, later followed by Sarmiento brace. Therein you can start mobilizing the shoulder as well as the elbow joint, so that the shoulder doesn't become. That is the protocol. Practice. Okay? If you immobilize the fracture for 6 to 8 weeks, the whole shoulder becomes stiff, very difficult to get the range of movements of the shoulder and also the elbow. So after 3 weeks, replace the European with a Sarmiento brace. They are available.
okay.
What is that you discussed?
Sir.
What was it? What is the common complication?
Sir.
Previous.
Mm.
This is what. Next.
Mm. What if with plating with bone graft for right humor, sir?
How many months old that fracture?
2 months, sir.
Iliac
Okay.
bone?
Sir?
Iliac bone, right?
Sir.
No. Distal neovascular deficit.
No,
Post-op.
no, sir.
Documented.
Yes, sir. Okay. Thank you, sir.
Done.
Good morning, sir. This is the case for discussion. Ganesh, 11-year-old boy, resident of Mehboob Nagar, came with complaints of swelling since 1 year in the left leg and pain since 6 months, sir. His
Would be to take clinical picture and then describe. That is better than the text.
Well, picture.
yes, sir.
Picture is very bad.
You need a new camera. Your own phone? Lighting.
It is one effective, but even then camera doesn't appear. Okay.
Uh, with a history of trauma 1 year back. They noticed the small swelling after the trauma, which was initially small in size, like peanut size, then gradually progressed to present size. Patient developed pain since 6 months, which is dull, aching, and it is bearable. Went for native treatment in the form of massages, and there is difficulty in daily activities due to pain. No history of fever, weight loss, or decreased appetite. No any other swelling present all over the body, sir. On examination, there is no scars. Inspection, no scars or sinuses. There is a solitary fusiform swelling. Yes. Sir? Oval shapes. No, sir. Oval shaped swellings. Extending from distal third of the leg to ankle crease. Surface is smooth, skin over the swelling is stretched, and there are dilated veins visible proximal to the swelling, sir. Yes, sir. Not over the swelling. They was like here, dilated veins. No visible. So many veins are there. Superficial veins are visible. No visible pulsations, no muscular wasting, and no limb length discrepancies. On palpation, there is local rise of temperature present. Tenderness is also present. The swelling is fusiform shaped. Margins are ill-defined, firm to hard in consistency, immobile, and non-pulsatile, sir. Skin over the swelling is pinchable. Part of the bone, sir. Arising from the bones. No, over the swelling, sir. Tenderness all over the swellings.
Don't show X-rays. We will discuss.
There is ankle dorsiflexion restricted. Only 10 degrees he is able to do, sir. Plantar flexion he is able to do. There is no distal neurovascular deficit or any regional lymphadenopathy.
How do you know the swelling is arising from the bone?
With we have to see the continuity with the bone,
So it's
merging with the bone,
that's what.
and it is bony hard. Skin is pinchable.
So variable consistency, firm consistency, soft consistency. Where do you get? Where do you get soft consistency? With soft consistency.
We'll discuss about this case.
Yeah. Okay, sir. Yes, sir. Go ahead, sir.
That you have to teach them when they are
Yeah, yeah.
individual. Okay. Don't
This,
show
no,
this.
okay.
Clinical.
Clinical.
You already
Keep the
open the puzzle.
clinical picture.
Clean.
Keep the clinical picture.
Interesting. Anybody? Second. So what do you think? Salient features. So whenever
It is
whenever
benign.
you see something salient. What is it? Benign. How do you know benign?
Slow growth, and
Malignant can't be slow growing. Slow growing.
But
it
the
can be
features what she has written here all are going in favor of
malignant.
dilated veins. Skin
Yes,
is
sir.
stretched and
Shine.
tenderness. All
Ah.
features are in favor of malignancy.
Hard in consistency also malignant.
How do you assure it not malignant? Clinically, with history and finding.
Rapid growth is not there, sir. Slow progressive.
Duration.
Duration. Age 11 years, sir.
Ask him age is back. Somebody standing in the back. She
Osteochondral.
knows everything. No point in asking her.
Skeletally immature. Distal third.
So what is it?
1 year duration.
Yes, sir.
Whenever we ask, we summarize. First age, sex,
Age.
location, all those things. Then that will lead to some diagnosis. Yes. Go on. What is it? So what could be the differential diagnosis? So first of all, I have decided the malignant or benign. You see, you think it's benign. Okay. So what could be the benign swellings arising at that site and that age with that duration? Name one. simple bone cyst. You've seen any simple? See, instead of speaking something irrelevant, better not say it. Because that will
Typically, what do you think now? Just when you got
speak to him. Jagdishwar.
It
He's
will.
answering. With a two-way. Let him answer. So irrelevant talking is not good. You don't know, that's it. Benign cyst cannot present like this. Jagdishwar already prompted him. Could it be infection? Could it be infection? So whenever
no.
you see swelling, how do you, what are the etiological things? Could it be congenital,
Developmental,
traumatic,
traumatic.
inflammatory, malignant? So you think it's a malignant?
No,
You
sir,
think
benign.
benign. You also think benign because you've seen, everybody's seen.
What are the features that you have written against benign?
Yes, sir.
One is history duration
History duration.
and rest pain.
Rest pain is not there.
Malignant
sir.
tumors will
Have rest pains.
there is no rest,
No night crash.
only
Tendon.
Okay?
Yes, sir.
No engorged veins. You
No.
go to dilated veins.
Dilated ones.
Dilated veins are varicose veins.
Yes.
Engorged veins are different, dilated veins.
Yes.
Okay? And no rapid growth recently.
Yes.
Recent increase in the size of the cell is a sign of
Malignancy.
benign tumor
Turning to me. Yes.
osteochondroma. And one more clinical finding what we have missed is you did not look for any pathological finding.
No pathological.
Okay?
Yes.
There is also an important possibility, especially in your fracture exam.
Okay.
The examiner will definitely try to look
No
at this
mobility.
because that is a very important thing.
Yes.
In the ambulance with pain or without pain.
Without pain. He is able to walk without pain, sir.
Without pain.
Without pain.
So any malignant tumor will have severe pain on this.
Yes.
When you say tenderness,
Tenderness on palpation, it is there, sir. All over.
tenderness is always palpation.
Yes, sir. But without
It is not acutely
acutely.
like a malignant.
Okay.
So the patient is standing and walking
Yes, sir.
without pain.
Without pain.
It's very, very important point. The rules of dash
Fracture.
or fracture.
मतलब pathological fracture.
Okay, can it be chronic osteomyelitis? Sir, I will ask.
But
How do you say that it is not chronic osteomyelitis?
there is no history of fever and any discharging sinuses.
Anything else?
Any signs? Chronic
No.
osteomyelitis, what is the common sign? What do you see
Sign.
on the skin?
Skin will be red and local rise of red. Acute. Chronic, there will be sinuses, discharging sinuses. Scars, pockets.
Scar or sinus? So you have to listen. You don't know that. That's important. You have to, I was that relevant talk.
Yes.
Just have to, you can't, you just can't say whatever comes to your mind. Think and say. Because whatever, every word of you counts.
Yes.
Everybody's. So we should not speak irrelevant or nonsense.
Usually in chronic osteomyelitis, you don't see an expanded type of diffuse bony swelling. Though involucrum might be there, but it will not produce a diffuse
Diffuse swelling.
oval so-called vortices. It doesn't produce such an expanding type of lesion. It looks like an expanding type of bony lesion.
Bony.
Expanding bone.
Expanding.
That we will see in the X-ray is the expand side or a new bone or a whole thing is a reactive new bone. We will see that. But clinically, we should be able to put, if not one diagnosis, at least two, three
Two,
differential signs. Can it be aneurysmal bone cyst?
Yes. It can.
Is it epiphyseal or metaphyseal?
Metaphyseal.
That also matters.
Metaphyseal.
So epiphyseal swellings are different, metaphyseal
Meta-
swellings, diaphyseal are different. This
But
is
the
how
diaphyseal then?
you narrow down the possibility.
Yes.
Meta-diaphyseal because it is
Meta.
sorry, meta epiphyseal.
Ep-
It is extending onto the joint. You don't feel a normal bone distal to the distal border of the
Border.
scapula. It is encroaching onto the ankle joint line.
Yes.
If you feel even a small narrow segment of normal distal tibia, you should be able to say it is a metaphyseal.
Metaphyseal.
Now it is encroaching onto the joint, it is epimetaphyseal.
Epimetaphyseal.
That narrows down the diagnosis.
So even if you know the diagnosis, you have to justify. Knowing diagnosis doesn't mean anything. Logically, you have to justify clinically. Okay, go on. X-ray. What investigations you did?
We have done an X-ray, sir. In X-ray, we can see the well-defined expansor lytic lesion involving the distal metadiaphyseal region of tibia, and pushing the fibula on the side, thinning of the cortices and cortex, sir, on this side, and it is eccentric, and epiphyseal growth plate is intact, sir.
So it's not.
Only
Basis is not involved.
non-involved, sir.
Growth plate is, it is encroaching onto the growth plate.
Onto the growth plate.
Can you say it is not damaged? Growth plate, the lateral part of the growth plate, can you say on the X-ray whether it got getting destroyed or not?
No, sir, we can't.
How do you say? You can't see that.
We can't say, but the growth plate is visible. Just
So you differentiate between physis and epiphysis.
physis.
Show me what is physis, what is it? So physis
This is epiphysis.
physis is
Physis growing end.
growth plate.
Growth plate.
Epiphysis is
This one.
sitting on top of physis.
Physis.
But the growth plate is setting.
Yes.
Directly there is no metaphysis here. So directly onto the though the epiphysis is intact, that's only. Okay.
Appears to me when you see the parallel line of the knee joint and the ankle joint, there is a valgus tilt of the salmon in the ankle joint. There is a tilt, see that? It is not horizontal. Probably it is the mass effect or part of the growth plate might have been destroyed. That is why the lateral half of the lateral 1/3 of the growth plate, if it is destroyed, the medial part of the growth plate keeps on contributing to the growth, and then if it is left alone like that, you will get progressive valgus, increased valgus. Already it is in valgus. See the tilt of the valgus.
Yes.
Okay,
Yes.
the ankle mortis is tilted laterally. That is probably due to disturbance in the growth of the lateral
Lateral.
1/3 of the growth plate. Probably I am suspecting that. Otherwise this could have been horizontal.
Describe complete now. Like the video.
So maybe.
No, sir.
Describe what reduction about the margins, about the expansion.
What is the matrix of the tumor, any periosteal reaction?
No
zone of
periosteal.
transition.
No
So do
periosteal.
you think it's arising from the bone or arising outside and compressing the bone?
Arising from the bones.
From the bone.
From the bone. The margins are sclerotic, sir, and
Bone
this
is involved.
lobulated one. From the cortex.
What is the diagnosis?
Is a cortical lesion or a medullary lesion?
This is a cortical lesions, because the center is here.
Interesting, very interesting. Okay, what else you can do?
We have done MRI, sir.
So is there a scalloping effect?
Yes, sir. Scalloping.
Scalloping effect?
This,
What about the different diagnosis? How many diagnoses can make with this swelling is there? Right is the
yes, sir. We can say aneurysm, bone cyst,
X-ray diagnosis and
Cron-
CT
aneurysm, bone cyst. It can be, sir. It can be an aneurysm, bone cyst, sir. Expansile, sir. Non-ossifying fibromas. Yes, fibrous cortical.
Fibrous cortical defect will be expanded.
Yes,
it will be a smaller lesion. The larger one variant of the fibrous cortical defect is non-ossified.
yes, sir. Osteo.
Maybe a large lesion.
Okay.
What is, can it be aneurysmal bone cyst?
It can be, sir.
Is it medullary?
Medullary.
Though metaphyseal, it can still be possible in children.
Okay, so,
And other possibilities,
Um,
chondromyxoid
chondromyxoid fibroma,
another lesion in children.
cortex,
Possible.
fibrous dysplasia.
Do you consider it as a variant of GCT?
GCT will be in the
Variant
variant.
of GCT. Can
Yes,
you tell
yes.
me what are the variants of GCT? 5, 6.
Non-ossifying fibroma,
Yes.
aneurysm bone cyst, unicameral bone cyst, and
GCT is different.
Variants, I said variants of
So
GCT.
don't say GCT variants. Giant cell variants are different. GCT variants, there is no word like GCT variant.
Giant cell variant.
Giant cell variant.
Giant cell variant. Giant cell
Varial hospital.
ಒಂದು వాళ్ళకు నేర్పించాలి.
Depends on
Clinics లో నేర్పించి then ask.
already told it. It's already presented here. Already presented here. Tell me what are the variants of giant cell. We said 3.
Yes.
All
No.
articulations of the bone.
uh,
Benign ones. Okay, next.
Next MRI scan.
this is the MRI scan.
Okay. Salient
Says-
features. See, whenever you
Sir,
see
there is-
the X-ray, MRI, you describe the features and you mentally prepare what could be the possibilities. You have to
Yes.
see you already PPT made. You should probably notes you have to make.
Yes.
Coming here and guessing is no good. Go ahead.
In this we can see it is a cortical lesion, sir, not involving the subcutaneous tissue, and it
So
is
the soft tissue is not subcutaneous. Soft
Soft-
tissue is
soft
normally
tissue.
not there.
not this, and the growth plate is also visible,
Growth plate is not.
not involved.
It appears intact. MRI.
Mm.
Growth rate is very much down.
Intact, but there is a pressure.
Pressure.
Yes, sir.
Metaphysis is completely damaged.
Damage. Lobulated, sir.
Okay.
It is lobulated, and
So from this MRI picture, would you say it's benign or malignant?
is benign, sir.
Why do you say it's benign?
Not involving the
First
It is-
finding you said.
yes,
If it is a malignant,
Malignant, it
what is
will-
called soft
soft
tissue.
tissue.
What do you think of vascularity? Any comment on vascularity? Do you think it's a vascular tumor?
No, sir.
Doesn't look like
No,
increased
sir.
vascularity.
No, sir.
Is it cystic or solid?
Solid, sir. It doesn't have any fluid filled cavities. Yes, sir. Fibula is pushed, sir.
Pressure effects. Pressure.
So could it be because this tumor is very, very differentiated?
Yes.
Do you think it could be arising from the soft tissue and pressing on the bone both sides? Do you think that's possible?
No, sir.
Why? It's well
It is from
well demarcated
well
from
demarc-
the rest of the bone.
yes.
Can you see? And it's rest of the nowhere it is it looks like a compressive lesion rather than arising from bone.
You have to see the other sequences.
Hmm.
Is the cortex of the parent tibia overlapping over this mass region? Continue to
Continuity is there.
see the cortex on this is expanding.
Yes, sir.
Any other sequences close up to axial cut? See, do the X-ray. That is a better idea.
X-ray.
X-ray.
Go back to the X-ray. X-ray. See that the cortex is expanding,
Yes.
overlapping over the fibula.
Can you see here? What?
Yes.
Are they,
Yes, sir.
so they say, see that is breach. And this part of the cortex looks as if it's going around the tumor.
Around that. Yes, sir.
It is an intracortical lesion. Okay. Yes,
Done.
proceed.
download. So what they did, written diagnosis?
They have given as a chondromyxoid fibroma or a non-ossifying.
What factors, irrespective of benign or malignant. Can you just make a diagnosis in a biopsy?
Histopathological examination. Okay.
So what are the criteria? Have you read any criteria? Read about tumor board. Any tumor treatment is based on tumor board discussion. Tumor board discussion, which will involve clinician, radiologist.
Radiologist. Yes, sir.
What biopsy?
True-cut biopsy. True-cut biopsy.
Not FNA.
FNAC.
Can you do any
It is-
FNAC?
If it is cystic, we can.
In the bones orthopedics, there is no role for FNAC. So no point in doing FNAC. We are orthopedic surgeons. We want to see the bone.
Bone.
You need tissue.
Tissue. Only fluid cells.
So we need, because
Tissues.
if you see, what is that, chondrosarcoma, you
See the
FNAC, they are
cells.
normal cells. So never depend on it.
FN.
True-cut biopsy.
True-cut
Open
biopsy.
biopsy.
Open biopsy. We
Can you
can.
do open biopsy? Incisional biopsy?
Yes, sir. We can.
Yes, but we need it here.
You can, but
You
it's
can.
needed.
No, sir.
No?
Because if we are planning for excision, complete excision or something, we can.
You can do it, but there's no need. You have to know types of biopsy. It's very
Yes. Superficial. Yeah.
If you are not a treating surgeon, better refer the patient directly to the surgeon who is going to treat, so that he will plan the needle biopsy site, so that it comes in the inclusion of the skin incision while it is being subjected to the definite.
Yeah.
or take his opinion.
And then proceed. It is not always feasible. But you can do biopsy and then treatment is done.
Yes.
Otherwise, they'll send everything out. So, what is the, when do you do other biopsies? You said true-cut biopsy, what else you can do? It's a small tumor, small mass, not tumor. What do you do? Have you heard of
okay.
any other types of biopsy, apart from incisional or open biopsy? Where you can take the entire mass out, what do you call it?
N block.
Huh?
N block resection.
En bloc is
Not breathing.
malignant tumors.
Excisional biopsy,
Excision.
small, you excise it,
Excise.
send entire thing to biopsy. That's
Biopsy.
all excision.
Excision.
You only do two things in orthopedics. True-cut
True-cut
biopsy,
biopsy.
or
Excisional
biopsy, majority of the times. Or CT guided biopsy, nowadays is very common. CT guided true-cut biopsy. That is very
Deep seated especially.
This one? Yeah, yeah. Come and present, read about it. Huh?
Apollo.
No, please. You want please? Yes. And get the biopsy
Okay.
before that.
Needle biopsy is done.
True-cut biopsy.
10 days.
Okay, next.
Biopsy is done already.
No, sir. No.
Which conditions do you do excision biopsy? Name 2, 3 clinical conditions where you do excision biopsy.
You can put
In,
your she will talk while she is discussing with the
We do it
Sir.
commonly here. Osteochondroma, you don't do a biopsy for that. Huh?
See, probably you know it, but you have to know how to express it. That's important.
And we got one more case of the knee also. That is also for this. Knee case. Yogi Sai, please come. Where is the case? Okay. That is also very good. Yogi Sai, please come. X-ray.
After this.
Yeah, this is also that, sir. That is also
Good morning, sir. My journal for today is medial patellofemoral ligament reconstruction. It's a surgical technique to dynamically control the graft tension. The abstract, the medial patellofemoral ligament is an important patellar stabilizer, and when damaged can lead to recurrent instability, cartilage injury, and debilitating pain among other conditions in patients with continued patellar instability after failed non-operative management. Medial patellofemoral ligament reconstruction often is recommended. A key step of the procedure is appropriate graft tensioning. Previously described technique can help guide the surgeon, but few allow for adjustable tensioning after dynamic examination of patellar tracking. To avoid over-tensioning, this technique offers the ability to dynamically control graft tension with two independent graft limbs while also using knotless onlay type fixation, therefore decreasing the risk of over or under tensioning and complications that come with it. Introduction. Sir. Sorry.
Technical. What is it? Next one. Every time is telling that there is no point in
Acute or indications and preoperative evaluation. Acute or recurrent instability after failed non-operative management. Imaging is radiograph with MRI to assess bone and soft tissue. Evaluate coronal alignment and patellar tracking and TTTG distance, height, trochlear dysplasia and rotation. And the equipment needed are two biocomposite knotless swive lock anchors and with two fiber wire and guide pins, reamers, interference screw and nitinol wire, free needle, graft. It might be semi-tendinosus and sometimes it might even be gracilis. 240 mm and double to 7 to 8 mm diameter. Graft preparation, both ends whip stitched with fiber loop, doubled and central 2 cm fiber looped, sized 7 to 8 mm for tunnel. Mounted on graft tensioning device, a semi-tendinosus allograft is used and both free ends are whip stitched with the fiber loop, and the graft is then doubled over and then central portion is fiber looped for 2 centimeters and sized for tunnel preparation. Patella preparation. 4 centimeter incision medial to the patella, expose retinacular and synovial layers. 2 guide pins placed parallel 15 millimeters apart from each other and ream 4.5 mm tunnels. Insert the knotless anchors. Avoid cortical and articular penetration. Skin and fat are incised and the medial border of the patella exposed with an intact retinacular layer. Retinacular layer is cut with exposed patella bone. Use a rongeur and decorticate the medial border of the patella. This is important for graft insertion. And femur preparation. Identify the Scottle's point for under fluoroscopy. Drill bicortical tunnel with ileated guide pin. Dock graft into tunnel and fix with bioabsorbable screw. Pass graft limbs between retinaculum and synovium to patella. And medial incision to get to Scottle's point and fluoroscopy to identify the Scottle's point. Guide pin through both cortices. Dynamic graft tensioning. Graft limbs looped through passing stitch at 30 degrees flexion. Use hemostat to secure provisional tension and assess the patella tracking dynamically through ROM. Adjust tension independently per limb as needed. Final graft fixation. Mark graft for final fixation. Pass repair stitch in inverted mattress fashion. Tighten the knotless fixation and tie circumferential stitch. Repeat for both limbs and close retinaculum. Advantages and disadvantages. Advantages are independent tensioning of both limbs, dynamic intraoperative tension assessment, and knotless onlay fixation for simplicity. And disadvantages are potential risk of patellar fracture due to anchor size, limited availability of smaller anchors, and requires fluoroscopic guidance for precision. And pearls and pitfalls. Assess patella tracking through ROM and adjust tension as needed. Tension each graft limb independently. Ensure graft passes beneath retinaculum and above the capsule. Avoid, and pitfalls are, avoid anterior cortical or articular penetration. Do not place anchors too close to the patellar edge. And failing to confirm the Scottish point under fluoroscopy may misplace the tunnel. Discussion. Graft tension critical. Overtension, medial overload, undertension and instability. Ideal tension unclear, but it is 2 to 10 in range, and knotless adjustable technique reduces overtension risk. Further studies needed for biomechanical validation. Conclusion. This MPFL reconstruction technique allows for dynamic intraoperative control of graft tension, independent tensioning of patellar limbs, and reduced risk of overtensioning and fracture with knotless fixation. Yes. Tishana, sir. The study based aim late, sir. It's most of procedure. Yes, sir. Techniques. Scottish point. Yes.
This is an arthroscopic procedure.
Yes.
Not an open procedure.
No. Patella open చేస్తాం సార్ ఓపెన్ అంటే ఆ స్కాట్లెస్ పాయింట్ దగ్గర ఫిమరల్ టనల్స్ అదొకటి ఎస్ some older techniques were there, sir. I didn't read about that. Sir? I don't know, sir.
Lateral release, medial plantation. Three-limb procedure. Three-limb procedure. That's better than this.
I don't.
So where you are taking care of the medial, lateral, and
Sir?